Good morning, everyone. My name is Eric McDonald, and I'm the Chief Medical Officer for the County of San Diego Health and Human Services Agency. We're here this morning to discuss COVID-19 medical and health misinformation. This session is being simultaneously translated into Spanish. And for those who are listening live, there is a link at the bottom of the page that you can click to listen to the Spanish version. And for those watching the recorded version, there is a separate video that will be posted on our website. I'm very pleased to be joined today by three local physicians for today's discussion. They are Dr. Christian Ramers. He's the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers of San Diego.
Centro Familiar de San Diego.
I'm hearing a little background there. He's board certified in internal medicine, infectious disease, and addiction medicine. I'm getting a little feedback still, so there we go, hopefully fixed. And holds faculty appointments at the UCSD School of Medicine and San Diego SDSU School of Public Health. He's on the San Diego County's Clinical Advisory Committee and Equity Task Force, and he's a member of the National IDSA CDC Clinical Call volunteer group that responds to questions from clinicians throughout the country. Dr. Ramers helped lead Family Health Center San Diego's COVID-19 monoclonal antibody infusion clinic sites also. We also have Dr. Francesca Cariani. She is a professor of clinical medicine in the Department of Medicine, Division of Infectious Diseases and Global Health at the University of California, San Diego. She currently serves as the program director of UC San Diego Health's Infection Prevention and Clinical Epidemiology and TB Control. During the COVID-19 pandemic, she served as a key member of the UC San Diego COVID-19 task force and was instrumental in helping shape university, county, and state pandemic COVID-19 responses. Our third panelist today is Dr. Sujana Gunta, who is a pediatrician and is Director of Pediatric Services at Vista Community Clinic. Dr. Gunta did her pediatric residency and holds a master's in epidemiology from the University of Iowa. And then she completed her pediatric nephrology fellowship at UC San Diego Rady Children's Hospital. I have to say that her love for primary care and desire to be in the community setting led her to Vista Community Clinic after her fellowship, and she does continue to practice pediatric nephrology at Rady's. She has spearheaded many efforts for her staff and the local community on COVID-19 vaccination at Vista Community Clinic. Our focus today is the Tuesday, November 7th COVID-19 update that was presented to the San Diego County Board of Supervisors. And we're just focusing on misinformation related to medical and health issues. As mentioned at the start of the other two panel sessions, the county has established a link on our longstanding website, coronavirus-sd.com, that is meant to assist the public in evaluating information on COVID. If you go to that website, there's a banner at the top marked Evaluating COVID-19 Information. By clicking there, you can learn more about the different types of incorrect information. There are links to credible sources. There are false claims that are paired with facts and some frequently asked questions. When we're done here this morning, this session will be posted on the website along with our previous panel sessions, and we will update the website as needed as new issues arise and new questions and concerns come up. There were three main areas that speakers at yesterday's meeting brought up for concerns and misinformation related to COVID-19. And those areas are the safety and efficacy or usefulness of the vaccines, the treatment or therapy for COVID-19, and testing for COVID-19. So I wanted to start with the panel with vaccines. And I know that all of you counsel patients every day about the vaccine. And I thought I would go around, perhaps starting with Dr. Gunta, about what your patients most frequently ask about and how you respond to those concerns. And I think in the course of this discussion, we'll be able to hit most of the things that were brought up in the meeting yesterday.
Yeah, being a pediatrician, I get a chance to, not only talk about the kids, but talk to the parents as well, and their own questions about the COVID-19 vaccine. Some of the recent questions or concerns that I've been hearing from them, one of which common question that I hear from them is, I've done well these last 18 months of the pandemic. I haven't had COVID. My immunity must be strong, so I don't need the COVID vaccine. And then I get I talk to them that I first of all congratulate them that they've stayed safe, and I want them to continue all the safe practices that they've been doing of social distancing and masking. But I want my patients to think about this as preventive, because vaccines are preventive medicine, and being a pediatrician, preventive medicine is so important for us. I encourage my patients to think about this just like eating healthy that they try to do, or exercising. I also point to them that if you haven't been in an accident, that doesn't mean you'd stop wearing a seatbelt just because you've never been in an accident. So we don't want to think about it as I've never had COVID, so I don't need the vaccine in the future as well. But we want our patients, we want all these children to have every tool that is available that their body could have in order to fight the virus when the body is facing this virus. And so just directing them to think about it more with terms of preventive medicine, like they've been doing for themselves and for their children, their family, all their life. This is another tool that, I want to encourage all patients and children to consider taking as well.
Thanks. Drs. Raymer or Cariani, any comments that you wanted to make? I can ask a couple of questions. I know sometimes people are concerned about what's specifically in the vaccine. There were inappropriate allegations that graphene oxide is in it, or that fetal tissue is in it. The vaccine does not make you magnetic. I mean, what are patients actually asking about or concerned about how the vaccine works or what's in it?
I can start and then maybe ask Dr. Cariani to follow. These are mRNA vaccines that do not change a host's DNA. People have billions of copies of mRNA in their own cells, and mRNA is a very fragile molecule that really comes and goes. And once the vaccine is given, it really, it produces its protein in a really ingenious way that is very elegant and actually much more delicate than many of the other vaccines that we use, which in effect are just viruses put in a blender or in formaldehyde and inactivated and injected. So these are actually much more targeted vaccines, and in that way, probably much more safe. So these are not gene therapy. They do not change people's DNA. And in that way, like I mentioned, are really much safer. In addition, these vaccines have really been studied in a way that many other vaccines have not. They've been under such scrutiny, and the 8 billion doses of COVID vaccines that have been given throughout the world, I think we have a very good handle of what some of the rare side effects are. I hear people that are very concerned about myocarditis. And of course, this is something that we need to know about. The first thing to say about that is myocarditis is more common with COVID-19 than it is with COVID-19 vaccines. And then even in the very highest risk group for getting this rare complication, which would be young adolescent boys, we're talking about 1 in 20,000 or so that may suffer this consequence, which is relatively mild. I think we have our pediatric infectious disease colleagues noting that myocarditis from a vaccine, they've seen some cases in San Diego, and they typically treat it with ibuprofen, and it results in a day or so of hospitalization with no long-term sequelae. And you really can't say the same thing about COVID-19. We have seen really awful, I keep bringing this up about long COVID, but there are some conditions and there are some patients that are suffering awful, awful consequences, even after relatively mild cases of COVID-19. And as far as we know, the only real way to prevent this from happening is to prevent a COVID-19 infection. And so the vaccines, which have been extensively studied, are incredibly safe, and they look to be effective. We can talk about the effectiveness maybe a little bit later, but they really are one of the best tools that we have.
Yeah, this is Francesca Toriani. The only thing I want to add is that these vaccines, unlike a lot of other vaccines, because of the way they were conceived, basically help not only prevent severe disease, but and death and hospitalization, which is the key element that they were built for. But unexpectedly, they also prevent disease itself. And so while they're not 100% protective, they're definitely very high. They give a high degree of protection that is much higher than, influenza vaccines, than pertussis vaccines, than other vaccines. And so we came with a relatively low barrier, but we got much more out of the vaccines than we expected. And this continues to be true throughout this vaccination campaign.
Now, I think it's worth sort of mentioning that, we all thought, hey, if we could get a vaccine that was only as good as the flu vaccine or is only as good as some of the vaccines we already had, that would be pretty good. And the early data we had really sort of set our expectations very high. I mean, not only was it doing its job, as you mentioned, to prevent severe outcomes, but it was really doing a very good job in the short run of actually preventing illness. Now we're learning as some time goes by that there is perhaps a need for a booster in many populations, if not most, and the efficacy for infection wanes over time. But I think we need to step back and remember that our expectations are so high from the beginning and should remain high actually with these continuing developments that we have with boosters, et cetera. And I know that Christian looks like you wanted to jump in.
Well, just over the effectiveness, we kind of talked about safety a little bit, but the effectiveness of the vaccines has been called into question because it is possible, once vaccinated, to have a breakthrough infection. And it is possible to transmit once somebody has been vaccinated, but the likelihood is so much lower. A paper just came out in the New England Journal of Medicine looking very carefully at viral load and transmission. And while it's true that with the Delta variant, which again makes up most of the infections in the United States right now, we saw this real increase in peak viral load that was kind of unprecedented, particularly in the outbreak that was on Cape Cod. And while it is true that vaccinated and unvaccinated people do reach the peak viral load that is similar with Delta variant infection, the slope or the fall of that viral load is much quicker in vaccinated people. And probably the infectiousness is much lower as well because they have lots of antibody around. And just because you can detect the virus with a PCR tells you nothing about whether that virus is surrounded by highly potent antibodies and is rendered non-infectious. So, people like to just glom onto this one little fact and say, see, you can transmit and you can have breakthrough infections in vaccinated people. And that's true. Nobody ever said that this was 100% effective, even from the very beginning. But we're talking about likelihoods, and the likelihood of having severe disease or hospitalization or death is so much higher in unvaccinated people. And the likelihood of transmission to other people is so much higher in unvaccinated people. And even the likelihood of getting infected, which again is beyond what we expected from these vaccines, is so much higher in people that are unvaccinated. So again, effectiveness looks really, really good. Now we're getting into the point where booster doses are being promoted, and we're dealing with the Omicron variant. And it looks like a third dose actually does restore a lot of the protection against the Omicron variant that was essentially lost when you have 2 doses only. And people say, well, how many more boosters are you going to need? Well, we use boosters for other vaccines as well. We do tetanus boosters every 10 years. We do another flu shot every year. We do 3-dose series for many of our hepatitis vaccines. Pertussis protection needs a booster. This is not really a foreign concept. And so again, it's the most effective thing that we have right now. And the data over and over again about how many people are ending up in the hospital and what proportion of them are unvaccinated is what's making us so tired and so weary of having to reinforce this point over and over again that, I just looked at our numbers, 92% of the hospitalizations in San Diego since March have been in unvaccinated people.
Dr. Wooten did a beautiful job yesterday of presenting the data just here in San Diego, which is really very similar to what's seen in California and across the country, that cases are 3 times higher in the unvaccinated compared to those who are fully vaccinated. They're 28 times higher for hospitalization, and they're 7 times higher for death. And I think what's important to know is that those who are hospitalized and die in San Diego with COVID tend to be 10 to 20 years younger on average if they are unvaccinated compared to the vaccinated. And again, that just is worth emphasizing. It's not that that we want to be only concerned about young people. We need to be concerned about everybody. But the stats here are very, very similar to what we see across the country. So,
Eric, if I could just follow up briefly, a lot of people are very big proponents of natural immunity, and we're learning a lot more about that. And there's a number of reasons why, I'm not going to discredit that natural immunity does help. We do see reduced reinfection rates with people that have prior infection. So it accounts for something, but it is very inconsistent. There are some studies showing that of those with a positive COVID test, 20% of them don't even ever seroconvert, meaning they don't really develop any antibodies. We're now seeing with the new variant, with the Omicron variant, that natural immunity probably doesn't help that much, and that the new variant can evade natural immunity. And then on top of everything, the people with the best protection are those that have had natural immunity and then gotten vaccinated. They have what's called hybrid immunity. Our former president of the United States has hybrid immunity, and this looks like it stands up the best. So if people really want to protect themselves from COVID-19, the combination of both is really the way to go. And the argument about natural immunity also just completely ignores all of those suffering from long COVID, which I've mentioned is this awful disease. You just sort of risk, am I going to be the one that develops long COVID? And it also completely ignores all of the hospitalization and death that you're playing with fire with if you take the chance of just trusting your own natural immunity. And I often like to say my entire career as an infectious disease specialist, and yours too, Dr. Toriani, is basically we see people that present to us because of the failure of their own natural immunity. So it's not a perfect system. Many, many infections, we do not develop a good enough response with the human immune system. And in fact, the ones that are getting the sickest in the hospital at day 10, 11, 12, and 13 after their infection, it's their own immune system that's really causing a lot of the problems. So it doesn't have to be one or the other. Like I mentioned, those that have gotten COVID and have a little bit of natural immunity, first of all, that wanes just like vaccine-mediated immunity, and it can be fortified and made better with vaccine, working together with those two different angles.
No, I think those are really important points, and I think that a lot of the speakers at the meeting yesterday tended to discount a lot of the really horrific effects of COVID-19 that aren't death. They just concentrate on that one little narrow aspect, and really the disability and hospitalizations and other effects are really, really quite tremendous. And they tended to overemphasize, I think, harm. We've talked in previous panels about the vaccine adverse reporting system and how you can't just add up whatever's in there and say, oh, those are all harms that are related to the vaccine in question. Again, there's a clear banner on the site that this is a passive surveillance system, and it's initial reports, and that you cannot infer causation in any of the reports that are in there. And I know that probably all of us have actually submitted bears into the system, and I thought maybe I'd give a chance to talk about that. It's a system that is part of a large system to look at vaccine adverse events in the country, but it works, and it is showing actually the safety of the vaccine. And I wonder if any of you have any comments on that. It looks like Dr. Cariani is nodding her head.
Yeah, so I mean, when we opened our vaccination stations, we had some reactions that caused us to pause and in the vaccination, and we did our homework, right? We reported them to VAERS, and that is a whole, if you have sufficient one type of reporting, that investigation then goes on by the FDA, CDC, all of those panels, and the company. So you have different panels that look at events that may be the same, and look at the chances that these events are spurious, or the chances that these are true events and therefore need a pause. And I think that that's a system that works, right? It's a system that allows for the information if there's a concern about an agent, whatever medication it is. You put it through this process, and it's a process that is very carefully put together with making sure that there isn't any influence from from that could not lead to an investigation that is sound. And I find it, the best system, because then you can look at all of these events and investigate, and it's an independent party that investigates these events, and then panels by multiple people that really go through carefully all of the events and the possible relatedness, and then assigns basically a protocol, or just a knowledge whether this is an event that is related. So all possible events go in, but very few then stick there, right? But all of them are investigated, which is the best system for a real world vaccination.
Yeah, and I would like to point out that it is through these wonderful systems like VAERS and VSafe that CDC instituted with the COVID vaccine that, some of the side effects that we talk about, the myocarditis or the Guillain-Barré syndrome, the few cases that we have seen, it is through this systems that we have come to realize those occasional side effects. So this again only proves to the fact that the system works. All the available data is analyzed, and what actually does make sense and could be a potential side effect is put out there, and we are told about it, and it's followed through very, very effectively. I also just wanted to mention that we talk so much about the hospitalizations and deaths, and that's why some of the parents bring up the fact that, or bring up the data that less number of kids are hospitalized, or there have been less deaths in pediatric patients. And I know this was mentioned in the previous session as well, but I just want to stress again that we're talking about young children over here. If, as a pediatrician, I don't want to lose a single child to any preventable disease. Why are kids in the age group of 5 to 11 or 12 to 17 even losing their life when I know a vaccine that is effective can significantly work to prevent death and severe disease and prolonged hospitalization and all those long COVID and the side effects of that. So again, it comes back to preventive medicine. All parents treat their children, they want to protect them, and this is a part of that. Like, you want to give them the best possible chance to fight the virus, and the vaccine is only helping them do that.
Thanks for that. I was had on my list of questions, why is it important for kids to get the vaccine? But I think you just hit that one out of the park. So I appreciate that. You know, one of the other concerns that was brought up yesterday was that one speaker said that all we're talking about is a vaccine, but that's not all we're talking about. And I'm wondering if you can talk to what you say to your patients that are things they can do to keep themselves safe from COVID that are beyond the vaccine that we all really still need to do. And maybe I'll start with you, Dr. Gunta, and I'll go around the table again.
Absolutely. So vaccines is one of the important tools that we, continue to talk about, but we definitely want to keep in mind that masking is just as an important tool, and social distancing, and continuing to adhere to the many guidelines that have been put out in minimizing indoor gatherings and all the other preventive measures that we talk about. There's also a lot of talk about, again, from a pediatrician point of view, about masking in schools. And I would like to, again, stress the fact that children, just as any adults, the virus goes through their system just as the spread occurs in the same manner. It still occurs through the respiratory system, and hence covering the mouth and the nose provides that protection and minimizes the spread of the virus from person to person. So besides vaccination, continuing to wear a mask in schools as well will significantly help reduce the spread of the virus. And again, like we know from the last 18 months, everyone has realized the importance of keeping our kids in school and getting that in-person education and how important that is. And if we want to continue to be able to do that, these tools of masking and vaccination and taking these other precautions become just as important if we want to continue to send our kids to school.
Thank you for that. Any additions?
I just want to emphasize the debate about masks, which shouldn't really be a debate in terms of whether they work or not. I mean, we have experimental evidence in laboratories that have been set up to simulate droplet transmission and things. And obviously the masks work exceedingly well in those studies. Cloth masks work okay, surgical masks work better, N95s and N90s work even better than that. We have real world information from masks where they've been implemented in schools, and universal masking is clearly associated with decreased transmission. And we have personal information being exposed to 50 to 60 highly infectious COVID patients every week. I have not actually contracted COVID yet, and I wear my N95 mask, religiously. These things just absolutely work, and there really shouldn't be a debate about whether they work at all. That's been very frustrating to me. There's somebody named Pierre Corey who was a sort of controversial figure pushing anti-vaccination things. And he wrote a long article on the website of the Frontline Clinicians, Critical Care Clinicians, and basically says masks absolutely work and need to be mandatory at indoor spaces. And they should be a part of a comprehensive prevention strategy. And it's just really, I don't understand how the message has just been lost, even amongst those people that are kind of pushing alternative therapies. Masks absolutely do work, and they really need to be part of our strategy. And we're not going to vaccinate our way out of the pandemic. We're not going to be able to treat our way out of the pandemic. It has to be a layered approach. And masks are really a simple, non-intrusive kind of thing that are essentially harmless. Ask any surgeon that wears a mask 12 hours in a row, really for most of the days of their life. They are harmless and very, very effective at preventing aerosol and droplet spread.
The other thing that we have to think, right, about is that masks or respirators have been used for the prevention of aerosols, not infectious, but also in the workplace, right? And so we have many business communities that wear masks for the protection of other hazards, and that goes on, in their daily working lives. And so there's a long history about this. In addition, I think what gets lost is really wearing a mask. The first foremost effect is protecting others. It's not protecting ourselves, right? It's a source control. If I'm infectious and I don't know that I'm infectious and I'm wearing a mask, that mask will protect everybody else around me. And so that is the first and foremost reason that people must be wearing masks as a layer of protection, as the Swiss cheese model, among all other non-pharmaceutical interventions.
In the interest of time, I'm going to move on to some quick questions about therapy and testing. And so maybe I could just, another open-ended question. If you have a patient with mild to moderate COVID symptoms, what treatment do you advise and what works and what doesn't? And maybe I'll start with Dr. Remmers on that.
Sure. Just a real brief historical note here, which is that almost all of last year, it was a very awkward place to be because we really didn't have much to offer at all. And it was frustrating because clinicians always want to do something and they don't want to just sit around and wait for people to get sicker. And so there was a real vacuum, a void in terms of early therapy, and groups jumped in and said, why are we waiting for these long clinical trials that are going to take a long time? Let's start using things that are reasonable. And that's really where vitamins came in, and hydroxychloroquine and azithromycin, and let's just jump before the evidence is really mature. We're now at the point where the evidence has had time to mature by and large. And many things that were tried early on are just showing that they don't really work at all and actually can do some harm. So hydroxychloroquine falls into that category. Azithromycin, which is an antibacterial agent with a little bit of anti-inflammatory qualities, probably doesn't really work. Ivermectin is really praised as an agent by a lot of people. It has in vitro activity against coronavirus, but the levels that need to be achieved in humans are very, very hard to achieve. And many of the studies that have been done on the NIH website, they run through 25 studies of ivermectin, and it's just not impressive. It, almost exactly equal to placebo in terms of many of the outcomes. And the few studies that have been positive showing an effect of ivermectin have been withdrawn because the data was falsified. So the process of actually looking at what really works is a tedious and painstaking process. I was just on a guideline committee for the WHO looking at hepatitis C treatments, and you have to get really down into the details of the study to decide what is the truth and what actually works. And in a disease where 80% of people have mild illness and are going to recover, it's not good enough just to take an anecdote, and say, I took vitamin C and I got better, therefore it works. You need to look at things very rigorously. And thus far, those three agents I went through really haven't worked very well. There's some other repurposed medicines like fluvoxamine and colchicine, which may have some activity. We run into limits because of their tolerability. It's very hard to take high doses of fluvoxamine or high doses of colchicine. It makes people nauseous and throw up. But additional studies will give us a little bit more information on that. Things like vitamin C and vitamin D and zinc are just not all that effective. There is some correlation with low vitamin D levels and infectious diseases outcomes, and that's why it piqued our interest. But used as a therapy, it really doesn't do much. It's almost too late at that point. So go ahead and take your vitamin D now as a supplement. That's fine. But the things that really work are the monoclonal antibodies are incredibly effective. We're talking 80 to 85% reduction in some of the bad outcomes like hospitalization and death. Those absolutely work. And so they should be central to fill that void of early treatment that people were asking for so long. That is really the one thing that we know absolutely works if used early enough. And then additional therapies are probably coming down the pike in terms of antiviral therapies. Molnupiravir was a little bit disappointing in the final cut, but still about 30% effective at reducing hospitalization or death. And then we have this Paxlovid coming out a little bit later as well. That'll probably be effective. But I just want to finish by saying the people that have pushed early treatment, I absolutely agree with the fundamental principle of treating early. You need to treat early. This is a disease that after about 10 days, the cat's out of the horse is out of the barn, the cat's out of the bag, and people can suffer terrible consequences from their own natural immune response. That's why people's lungs fill up with fluid and they can't oxygenate anymore. And quite honestly, that's why they die, and why we're using steroids to try to keep them alive to suppress that immune response. But the idea that all of these things that really don't have much evidence behind them should be thrown at people like a kitchen sink is just not the way we practice medicine. And in fact, some of the websites that put together these protocols have very large disclaimers on them that say this does not consist of medical advice. The main one pushing ivermectin says the information provided on this website should not be used to diagnose or treat any medical condition. They say this does not constitute any medical advice, nor should it be interpreted as medical advice. And they say, finally, these products on this website have not been proven to be safe or effective. So you have a lot of people saying, well, I've heard an anecdote, I heard a story, I really want to believe that this works, and so I should try it. But even the people that are pushing this realize that these have not been proven, and yet there are other things that absolutely have been proven, like vaccines to prevent the infection in the first place, and like monoclonal antibodies or other antivirals that are coming soon.
Yeah, that's very thorough, Dr. Reimers. I really appreciate that review. And then, one of the folks yesterday, and I'm going to let Dr. Cariani maybe handle this one, that one of the folks yesterday said that, it was remdesivir that was killing COVID patients, not COVID. And, you've taken care of patients, you've actually used remdesivir in your practice. I wonder if you can, I sort of hate to be sort of graphic about this, but what's killing COVID patients?
So as Dr. Reimers just said, it's most of what is happening is really our own immune system reacting to the virus and getting really bad pulmonary disease, lung disease with respiratory failure, and then the need for ventilation, so for mechanical support, and simply then the impossibility to maintain a good ventilation system and a good cardiovascular system, and all of the other complications of COVID-19. I think remdesivir was the only tool we had at the beginning. And so that's what was studied. The effect is really mild. We combine it with steroids to decrease the inflammation. But as Dr. Reimers said, this is really, it's our body responding to this infection and reacting that is causing most of the declines and issues here and death. And what I would want to say is that what we see, the differences between, the vaccinated population needing hospitalization and the unvaccinated population, as you said, the unvaccinated population coming in with sickness now, we're seeing much lower age groups, not necessarily with, really bad underlying diseases, except for diabetes, hypertension, and obesity. What we see in the vaccinated population is really populations that are immunocompromised, like transplant recipients, and morbidly obese patients who already have problems. And so we see, or cancer populations. So we see disease that can be severe, but once again, it's a minority of those who present with disease, even though they're immunocompromised, who need hospitalization.
Thanks. I just wanted to finish off with two more questions, and one I just wanted to move on to tests. People brought up the fact that that the PCR technology is not one that we can be relying upon to diagnose disease. I think we all know that that's just untrue, frankly. Somebody made the comment that there's no way to tell the difference between the common cold and SARS-CoV-2 using PCR, and that's just not true. We actually can tell the difference. In fact, we can tell the many different viruses that cause what most people would call a common cold, whether it's an enterovirus or a rhinovirus or a coronavirus that's not SARS-CoV-2. So that I just want to point out that those are just absolute false, demonstrably false statements. But one of the things that did come up was the utility of antibody tests. And so I'm wondering if anybody wanted to comment on that. A specific issue is, is it useful from your perspective for individual patients to know whether they're positive or not, and or is there a role for that in clinical management?
Yeah, I'll start with that one. I think there is a role for antibody testing if you want to find out if somebody's been exposed to the virus. So I use this with patients. Some patients have mysterious long COVID symptoms, like I've been saying, and we don't know how to explain them. And I check a nucleocapsid antibody that tells me, yes, they have been exposed to COVID. And that is a useful thing to do. In terms of checking a spike antibody, which might be misinterpreted as providing protection, there's a lot of problems with it. The first is that the tests initially were quite unreliable, and they've gotten a little bit better. So that's a good thing. But the tests that are used in research studies to really correlate with protection and to show real neutralization are very, very different than what's available in the clinic. So I can send a test and it can give me a level of X, Y, or Z in terms of somebody's antibody. That does not tell me the quality of that antibody, does not tell me whether it's a neutralizing antibody, and we have no idea what level is going to actually provide adequate protection. So that's the reason why CDC has been reluctant to tell people to use antibody tests in terms of making clinical decisions. And I know people want to say, well, but if I have antibodies, that's just as good as being vaccinated. And that's just not true either. There are other countries, I will say, to be a little bit contrarian. In Europe, some of the vaccine passport programs that, allow you to enter a restaurant or a gym will accept a recent COVID test, but only for a couple of months. And that's because we know that natural immunity wanes just like vaccine-mediated immunity. And it is exceedingly rare to be reinfected within the first couple of months after getting an infection. But again, that's a side conversation separate from the actual antibody testing.
Thanks. Any other comments about tests? I think I hopefully dealt with the PCR test, and I refer people to our first panel in which we had a laboratorian actually going through PCR technology in more detail, just in the interest of time. I really did want to go around. Francesca, Dr. Toriani, sorry.
One thing that doesn't matter. I can be Francesca too. One thing that I think is important, right? I think diagnostics are a tool. And so what we've seen in Europe and in other countries is this availability of free tests, right, to families, to members of families, so that they can decide when they want to test. And I think that even though these are not, these are antigen-based tests and less sensitive, less specific, but less sensitive. But the point is they can be an additional tool. And so this is all the layers of Swiss cheese protection. Testing is one of these tools. And so if in the United States we can get better access to testing, home testing capability, that will be really useful for people so that they can monitor immediately and then seek care if their test is positive.
I wanted to go around the horn one more time to see if there's anything that we haven't talked about that is, I think worth talking about in terms of either misinformation or misunderstandings that you are encountering with your practice with your individual patients or your family or friends regarding COVID. And I'd like to, again, start with Dr. Gunta one more time and go around.
Yeah, I would like to advocate vaccines for all age groups, and the most recent age group that's been added is the 5 to 11 year age group. So highly recommend for that age group as well. If parents are only looking at data and saying that it's not affecting children as much, I again would like to point that we don't want children in this age group hospitalized. We don't want them in the ICU. We don't want a single child dying of a preventable condition. And also, the data has shown that the subsequent waves of the pandemic has actually caused more severe forms of illness, the MISC, the multi-system inflammatory syndrome in children that we've been talking about, that it's been more severe in the subsequent waves of the pandemic. So we don't know what else is in store. But what we do know is vaccines are helping prevent the severe forms of the disease. Vaccines are preventing the illness itself, along with other layers of protection like masking. So please talk to your pediatrician about this and get vaccinated.
So I'll go next. I think, I really applaud you, Dr. McDonald, for doing this effort in misinformation. As you know, the Surgeon General of the United States is also trying to do a similar initiative, because those of us that are seeing patients clinically are continually seeing the consequences of people making decisions that are not in their own interest. And I'll give you just one anecdote. A patient with a genetic syndrome who also had cardiovascular disease, who was in my monoclonal clinic, very ill and really on the borderline of needing to be hospitalized. And that patient's parent said, well, I was so scared of myocarditis for my child, who is an adult now, by the way. But, so I looked at the risk, and it was about 1 in 200,000, the risk for this individual to get myocarditis from the vaccine. And yet he's in front of me, really at risk of being hospitalized, and probably a 100-fold higher risk of getting myocarditis from COVID. And we are just seeing this over and over and over again in the hospital and in our clinics, that people are, latching onto something that they want to believe in because they don't like the idea of government control. And yet those of us that are clinicians and that are public health professionals are really just trying to give good advice based on scientific evidence. People that go to work for the CDC or people that go to work for the County of San Diego's public health department don't have an alternative agenda. We all just want to use the facts to protect our populations. And we have very clear evidence that the vaccines are safe and effective. It's the best way to prevent what's going on, the best way to prevent long COVID, again, which is that other outcome that is so important. And really, it's the best way to get us through this whole thing together. And so I think we need to continue to push back against the misinformation that's out there and just provide good advice for people. The one last really individual point that I wanted to make is people that have recovered from COVID still should get vaccinated as well. And they may be the best protected among us if they get fully vaccinated after recovering from COVID, especially as these new variants come in. Papers are just coming out now that hybrid immunity looks like it's king, really, against the Omicron variant. So those that have recovered, please do get your vaccination. You are not fully protected against this new variant that's coming in. You still need to be vaccinated.
I'll let you have the last word, Dr. Cariani.
The one thing I want to say is that we've learned a lot during this pandemic. One thing that we've learned is that things are, there's some truths that continue to be perpetuated, and then there's some myths that start out and that are dispelled. And so it is a changing field, right? When we started in this pandemic, in infection prevention, the concept of masking out in society was not a concept that was in our minds. And we quickly got to universal masking because we realized that the data was telling us that was a good measure, that source control, using source control universally was best. And so I think we have to be very careful. One field that is very dear to me, and Dr. Gunther spoke about, was the vaccination in the 5 to 11 group, which was seeing disproportionately affected now that they're back in school. So we want them to be safe in school. We don't want them to be not safe in school, and they need face-to-face education. They need to be in school to get all the emotional learning that they can get. They can't be at home in front of a computer. And so there's more than just the consequences of getting COVID. There's also the consequences of depression, of getting bad disease, of education lost in these kids. And so we need to do our part and protect them from that. The second population that I think was really hardly hit is the pregnant population. We held off because of fears of vaccine and effects. We held off a very long time from recommending vaccination in pregnant women. And then we saw the effects of this infection in pregnant women and the lives lost once again and the severe disease. And so we want to be ahead of the curve, right? And that is why we're doing infectious diseases. That is why we are working in public health. We want to be ahead of the curve.
Well, that's a really good note to end on. I want to thank all of our participants today, Drs. Ramers, Gunther, and Toriani. I also want to thank the organizations you represent, all of your fellow practitioners, and frankly, your entire staff, down to the janitors and security guards that work in your organizations. Really, you are doing the work that's keeping our county safe. So on behalf of San Diegans, I thank you, and all the organizations that are not represented here. Again, thank you truly for your time, that you took it away from your patients and your own staff to do this for us. So I appreciate it, and I'll sign off there.